Hello, I am Manasi Jayaprakash, Program Operations Director at the Center for Asian Health Equity, University of Chicago. I am representing our team today to present on one component of our programs where we established timely linkage to diagnostic colonoscopy through technology solution. I am extremely thankful to Prevent Cancer Foundation for providing this platform to present our work. At the outset, I have no relevant financial relationships. Our technology solution is part of two funded programs two ongoing programs that are funded by the Centers for Disease Control and Prevention's Colorectal Cancer Control Program and the National Cancer Institute's Moonshot Initiative. We were also previously funded by the Prevent Cancer Foundation for this work. Now, we all know that the burden for colorectal cancer is real, with colorectal cancer being the second leading cause of cancer deaths. You can see some numbers here on the new cases, on the estimated new cases and deaths in 2021. The most important fact is that screening for colorectal cancer is effective. There are several screening modalities which pose both a challenge and a success. The success is that some tests like the stool-based tests can be performed in the convenience of patients' homes. However, the challenge is that abnormal stool-based tests need to be followed up with timely diagnostic colonoscopy. Now, screening is effective when started early and when the loop is closed. Now, in fact, 9 in 10 cancer deaths can be prevented. Yet, 23 million individuals have not been screened, and 85% of them are actually insured. And we know that the pandemic has had a detrimental effect on colorectal cancer screening, with closures of GI units or gastroenterology units for elective procedures in the early months of the pandemic. Now, it's estimated that there will be additional 4,500 additional colorectal cancer deaths due to the pandemic. Now, because of the pandemic, we not only have these millions of individuals who have not been screened, but we also have additional individuals who've missed screenings and who have delayed diagnosis, thus really amplifying the burden of colorectal cancer. Now, when we look at colorectal cancer screening status across the United States, we see that Illinois state is in the last quartile for colorectal cancer screening. Within Illinois, there is significant regional variation, with many rural counties below state average. In fact, southern part of Illinois extends into the nationally designated colorectal cancer mortality hotspots. There are only 3 hotspots across the nation. Now, in Cook County, which is the top right-hand corner of Illinois, that is home to Chicago, we see a high incidence of colon cancer here, despite the abundance of hospitals providing specialty care, and also the high density of community health centers, as seen by the distribution of red and blue that represent both hospitals and federally qualified health centers. As incidence is also high, concurrently, the screening rates are below state average in Chicago. While access to care contributes to low screening rates, the inability to fully utilize existing healthcare resources accentuates the problem. Several of our health center partners are unable to track patients once a referral is made. They're unaware that majority of their patients with the referral did not make it to a procedure. And even if patients completed procedures, they did not receive reports back in a timely manner. Now, this problem can be visualized across the different levels that contribute to a fragmented healthcare system. At the provider level, poor communication between providers and specialists can lead to delays in diagnosis, medical errors, and unnecessary testing. At the patient level, we know that stool-based screenings are effective, when abnormal stool tests are followed up with timely diagnostic colonoscopies. The reality is that 50% of referrals fail to result in a procedure. And no point of service specialty care scheduling leads to failed screening. This in turn leads to unfilled capacity in hospitals, almost to the tune of 24% unfilled procedures in GI units across the country and across both urban and rural settings. This is simply missed revenue for hospitals. And this repetitive pattern of fragmentation has grave societal consequences. For our example here, that would be called colon cancer. And we are here to disrupt this pattern. So we developed a solution, a technology solution, the Illinois ColonCares.org portal, as an end-to-end solution to link patients to colonoscopy services in partnership with staff at our community health clinics. This really stemmed from our community health center providers not wanting to screen their patients since they had no mechanism for follow-up care. Our innovative team then, back in 2017, developed the web-based portal that's HIPAA compliant. The portal connects out-of-network health systems for ease of communication between providers, enables scheduling and access to quality care. Now, how does our solution work? It all starts with hospitals allocating slots in the web-based portal to fill their capacity. The clinic staff are able to log in to the portal when the patient is available with them. The clinics can then see the availability of several slots and schedule patient appointment before patient leaves the clinic, thereby providing point-of-care scheduling. Patients are then walking out with appointment time along with instructions on prep and the colonoscopy procedure. Meanwhile, the hospital gets to confirm the patient within the portal without the need for fax or phone and with the ability to communicate within the portal. The patient then completes colonoscopy at the hospital to reduce colorectal cancer risk. After the procedure is completed, hospital then uploads the reports on the portal and clinics receive their patients' results, including quality benchmarks, thus closing the information gap and also sharing quality metrics. While the patient's in the hospital side, the clinic is able to visualize at what stage of completion the patient is at. Thus, they're able to track their patients. So the portal enables out-of-network communication and also bi-directional communication. So our impact is measurable. Our solution has contributed to early detection. Of the completed patients, 44% of them had precancerous polyps that were removed. Now, almost all of them had good bowel prep. There was only one no-show patient during the pilot phase. The pilot phase started in 2017, and we have expanded the portal over the last year. 85% of scheduled patients completed their exam. Now, it's 85% and not 95% because of the pandemic, where several procedures were canceled and rescheduled. Of all the patients scheduled, 90% of them were uninsured, thus meeting the critical need of access for our vulnerable patients. One of the uninsured patients was diagnosed with stage 1 cancer, and they were able to get cured. Wait time for these uninsured patients was reduced from 18 months to less than a month, thus contributing to early detection. Now, all participating clinics are either federally qualified health centers or free clinics in Chicago. We are excited to roll out our technology solution with rural partners this year. We have learned that building on existing relationships between clinics and hospitals or neighboring hospitals is important in ensuring successful implementation of the solution. So this is our innovative team implementing our technology solution. So thank you for listening. And that concludes my presentation.